Good morning. The weather is nice, so I would try to be a little quick so we can all enjoy the weather. My topic of discussion today is the role of percutaneous intervention in obstructive TAPVR. Just a basic thing that TAPVR, TAPVC is an anomalous drainage of pulmonary veins. It means the pulmonary veins are not draining into the LA, they are rather draining into the right atrium through some systemic vein or directly into the RA. The important thing is that untreated cases have very high mortality rate. This is the classification based on the site of drainage. I will skip it. There are more ways to classify, but one of the most important thing to classify the TAPVR or TAPVC is whether it's obstructed or unobstructed. It will determine actually the prognosis, the surgical results. This is a pretty old paper from 1982. They studied the natural history of TAPVC. If you can see here, the median survival in the unobstructed group was just 2.5 months, and in the obstructed group it was just 3 weeks. So we need to be spot on with the diagnosis and the management. The existence of obstructed lesion is the most critical. It's most critical part in the determining the prognosis. It's true life-threatening emergency and needs urgent surgical intervention. The problem with the surgery is that it still carries very high mortality rate. This was a study which was carried out in one of the neighboring countries. They showed the mortality was 23%. So operated mortality for TAPVC was 23%. Another paper which was published in 1991, it showed the mortality of around 50%. This was a 10-year experience from China. Again, the mortality rate was around 13%. Similarly, from USA, this was just a comparison between infracardiac and non-infracardiac. This was a French data from 1973 to 2014. Studied 180 patients who were operated. Again, the mortality was very high. It was alarmingly high, like 27%. Although it has come down to 7.4% after 2010, but still high. Another Mexican study around survival was 87%. So the problem with the surgery is that they have to operate upon on the younger patient with low body weights who are having preoperative pulmonary venous obstructions, and the saturation is low. Then the bypass time is usually prolonged. So there are multiple issues. And the other thing which is on this side, if you can see with the TAPVC, if we combine with single ventricle, this all is very bad prognostic feature for mortality in the TAPVC. So here, as a cardiologist, just to collaborate with a surgeon and to help the patient, if we can, as a cardiologist, make these patients from obstructed TAPVC to unobstructed, this can gain time in medically optimizing these patients before the definitive repair. I will skip this. This is so the important thing that we need to understand where the obstruction can occur in the TAPVC. So first of all, they can have restricted interatrial opening, intrinsic narrowing of the venous channel, then external obstructions and internal compressions, and external compression and internal narrowing as well. So this was a 4-day-old male who had a supracardiac TAPVC. So chest X-ray, you can see here the ground glass appearance signifying the pulmonary venous hypertension, and in the echo you can see the compressed vertical vein between the LPA and left main bronchus. So here they did this is paper published I think in 2018. So they did the stenting here in the ascending vein. Another case which was published in 2016, 1.7 kilo baby with the omphalocele and multiple other issues. He had a stent placement in the supracardiac TAPVC. Again, another child who was stented at 12 hours of age. And then there are multiple other case reports as well. Similarly, infracardiac TAPVC can also have the intervention like stenting of the vertical vein or ductus venosus. This was a case of severe narrowing of the vertical vein at the joining of ductus venosus. So here we can see that they put the stent here in the vertical vein. Another case where they put the stent in the vertical vein and ductus venosus. And then there are multiple other case reports. just 2-3 slides more of intervention. So this is when they have got small AST, we can do the balloon septostomy, or we can stent the atrial septum. In this case, they just put a wire and stented the atrial septum, and before they operated upon this small kid. Another interesting option is to do the stent insertion between the left atrium and pulmonary venous confluence. This is hybrid. You have to open the chest, and surgeon will help to put the needle in the LA and the pulmonary venous confluence, and then we can put the covered stent. Here you can see there was stenosis in the vertical vein at the diaphragm level. This is a balloon, and here they put the stent, and you can see the lot of flow is now going into the LA, and the echocardiographic image is also shown. ECMO is another option if it is available. This is one of the interesting paper which is published from Japan a few months ago. So what they did was they studied these 29 patients who required neonatal intervention for obstructed TAPVC. So they divided into two groups. One was that in the 11 patients they did the primary draining vein stenting and delayed the surgery, and while in other 18 patients they do the primary surgery. And if you look in this table, the primary stenting group had a survival of 100% at 90 days, whereas in the surgical group, which is a primary surgical group, it was just 56 days. If you can see here, the mortality in this group was 61 as compared to 36%. So just last few slides, this was my experience from Army Cardiac Center. I did a case last year. So this baby girl was 2.5 months old, presented to us with severe central cyanosis, metabolic acidosis, and respiratory distress. Her pH was 6.9, depleted by carbs, and SATs were around 50%. So this is her echo. So you can see there was a dilatation of the right atrium and right ventricle with the mild to moderate TR with the pressure gradient of 113. So there was severe pulmonary hypertension. And if we see here, all the pulmonary vein make a confluence and then ascend to the innominate vein through this vertical vein, which was constricted, externally compressed between the LP and the main bronchus. As we know, we don't have a surgeon at Army Cardiac Center, so after discussion with Intasar and the family, we thought we can do the intervention just to save the child and do the surgery later on. So I put a 5 French sheath in the femoral vein, took a 5 French JR. This is through right atrium, SVC, innominate. Here was the obstruction. You can see there was no flow coming from, you can't see any flow coming from below. Cross the stenotic area, so you can see the very severe stenosis of the ascending vein, and these are the pulmonary veins and the confluence. Cross with the Teromo wire, change to the coronary wire, and I did just ballooning with 8 millimeter balloon. So just to make it complete, so we overinflated, resulted in the busting of the balloon. But if you see here and compare this one to this one, there's a lot more difference between the caliber and the flow of the vertical vein. And the baby had a very nice result, and he followed up for like 2, 3, 4 days, remained in the NICU. And this was his post-op echo. You can see a lot of flow now going from the pulmonary vein to ascending vein. The PG was reduced from 23 to 13. And I got this published in Curious Journal a few months ago. So the take-home message is that it should be clear that obstructed TABC is a surgical emergency. We need urgent intervention. But the problem with the surgical intervention is the cardiopulmonary bypass, which can be counterproductive in some babies. It can result in pulmonary edema, increases the mortality. So if transcatheter intervention is feasible, it may prevent high surgical mortality in this patient population. It may stabilize a sick neonate and can act as a bridge to surgical repair that can be performed on a more stable patient. It may be wise to say that transcatheter relief of obstructed TAPVC may be used as a first choice treatment against neonate under extremely critical condition, and especially with the babies who are born with a single ventricle physiology. Sir, thank you very much.